All right, good morning, everybody. Welcome to Pediatric Grand Rounds. Before we get started, just the usual reminders and disclosures from me. Please make sure to stay muted during the presentation. And when you have questions or comments for our speakers, please add them to the chat with everyone box at the bottom of your screen, and we will share them with the speakers at the end of the presentation, at the end of the hour. You'll be getting an evaluation by email from our team today or tomorrow. Please make sure to fill that out for us as it helps us inform future Grand Rounds topics. And finally, a disclosure statement from me. The planners for Grand Rounds have no relevant financial relationships to disclose. And so now I will turn things over to Dr. Lori Ruttman, who is the director of the University of Washington and Seattle Children's Hospital Quality Improvement Scholars Program. Thank you so much, and I'll turn it over to you, Lori.
Thanks so much, Suzanne. So as Suzanne mentioned, I'm Lori Ruttman. I'm a physician in the Division of Pediatric Emergency Medicine here at Seattle Children's and director of the UW Medicine Seattle Children's Quality Improvement Scholars Program. I'm absolutely thrilled to share a bit about our program with you today. So none of today's presenters have financial relationships or conflicts of interest to disclose. And today I'm really going to give a brief overview of the QI Scholars Program and introduce to you the 2020 to 2021 scholars. Each will present their project, the project that they've been working on. And then at the end, we should have about 10 minutes for questions, both about the projects or also just about the program in general. So please hold any of your questions and comments until then. So QI Scholars began in 2015 with a goal to really increase faculty expertise related to rigorous evaluation of quality improvement activities that were happening every day in the Department of Pediatrics and at Seattle Children's Hospital. There are three components to the program: the QI Research Project, monthly seminar attendance, and then participation in works in progress sessions. When the program begins every October, each scholar is paired with a mentor experienced in QI research methodologies. They meet twice each month to work on project design, identify the data needed to complete their project, and then they work with the clinical analytics and stats team to obtain the data that they need. The mentor and the scholar work together to interpret the data analysis that's received from their statistical team, and eventually they draft and submit a manuscript based on their results. QI Scholars has multiple experienced statisticians on our program faculty, and each scholar is paired with a statistician and a data analyst with whom they meet monthly as needed to discuss any of the analytic needs that are coming up with the scholar's project. Scholars are also provided with project funds to support research assistants, data analysts, statisticians, and other related costs. So our program faculty are listed here. Again, really one of the strengths of this program is the dedicated support that each scholar receives, both to maximize their learning and to ensure that their projects are a success. Our monthly seminar series makes up the program's didactic sessions, and it really focuses on state-of-the-art QI research methods. Seminar attendance is required for the scholars, though we also have a few spots in every session for those who are interested in just auditing some of the session content. Currently, about 6 of the seminars are given by outside speakers from institutions including Cincinnati Children's Hospital, the Harvard School of Public Health, and the Permanente Washington Health Research Institute. And then 6 of the seminars are given by UW Department of Pediatrics faculty and also UW Medicine faculty. Seminars are generally on Tuesdays from 9 a.m. to 1 p.m. and usually the first or second Tuesday of the month, depending on our speakers' availability. So the curriculum is listed here. Each seminar is 4 hours long, of which really less than half of that is lecture, and the rest is designed to be interactive exercises to teach scholars how to apply the material that they're learning to their own projects. Ideally, these sessions are in person, so scholars are able to interact directly with the faculty, really build community and learn from each other. This year, we started fully remote because of COVID, And we've now shifted to a hybrid model. So we'll see what next year brings. We're hoping as much as possible to get scholars together in the same room because that interaction and community building is really a big part of the program. We do provide readings before and after the seminars, so the scholars have access to those, and then the slide presentations are always available for their use. The final component of the program are the work in progress sessions. And these sessions are held quarterly with all program faculty and scholars. The scholars present their work to date and get feedback from their peers, mentors, program faculty. They're also encouraged to attend the monthly QI research work in progress sessions, or WIPs, that happen on the fourth Wednesday of every month at 2 p.m. At these sessions, a wide range of QI research is presented, from grant proposals to fellowship research projects to hospital QI work. And every year, usually in November and December, the QI scholars present their projects to that group as well, mostly as they are preparing for their presentation in the spring for grand rounds, which is what we're doing today. There are some exciting changes to the program this current year. So the first thing is that we expanded our cohort to welcome new scholars from across the UW Medicine system. So this new cohort of scholars includes 5 faculty from Harborview, UW Montlake, and the VA. They've joined our children's scholars for the seminar series and work in progress sessions. And really, this expansion has been just an incredible opportunity for greater collaboration and learning across the broader health system. On the children's side of the program, we expanded to include a scholar from the Center for Quality and Patient Safety. And again, including a leader who's engaged in QI at the hospital microsystem level has been just a wonderful opportunity for shared learning and collaboration. For 2022 to 2023, we're again going to have up to 4 scholar spots for assistant or associate professors in the clinician scholar or academic clinician tracks, and up to 1 to 2 spots for faculty from the Center for Patient Safety and Quality. Generally, the FTE for this program is provided by the individual scholars department or division as a release from clinical responsibility, so that scholars are able to really engage with the program and attend all of the seminar sessions. So QI Scholars is now in its 7th year, and it's reached 13 different subspecialties, including now the additional subspecialties on the UW Medicine side. So we're really proud of the reach of this program. And then some key dates for the upcoming program cycle, in case you're interested in applying or you know someone who might be a good fit for this program. The program announcement and the request for applications should go out around June 15th. Applications will be due on August 29th, and scholars will be announced by September 6th. The program officially begins in the beginning of October. The first seminar is usually mid-October, and then the program ends the following September. We do offer a 1-year extension on the statistical support and data support because many scholars need 2 full years to actually get their full analysis done, but the content and the seminar attendance ends after that first year. We also have a site on Child. It's under Research Centers and Programs, QI Scholars, where you can view the current scholars. All of our program faculty have bios there. Our QI Scholars alumni are all listed on that site, and you can also see some of the amazing work that our alumni have accomplished. So without further ado, I'd really like to introduce the scholars who are presenting today, because they are the stars of this Grand Rounds presentation. First, we're going to hear from Dr. Pearl Chang from Hospital Medicine. Next, we'll hear from Dr. Meenal Gupta from Endocrinology. After Meenal, we will hear from Dr. Kirti Upadhyay from the NICU. He'll present his project. And then finally, we'll hear from Dr. Anita Thomas from Emergency Medicine. So again, I ask that you just please hold your questions until the end. The scholars have all timed their presentations really tightly, and we want to be sure everyone has time to present. We will definitely take questions and comments at the end of the talk. So without further ado, I would love to hand it over to Dr. Pearl Chang for her first presentation. Thank you.
Okay, good morning, everyone. I guess we're off to a good start because I got my screen to share and everything. Thank you for the opportunity to present my project, Reducing IV Antibiotic Duration for Neonatal E. coli UTI using a Standard Care Pathway. I have no disclosures. Urinary tract infections are the most common bacterial infections in young infants. Unfortunately, there is currently no consensus on the duration of IV antibiotic treatment of UTIs in infants less than 1 month of age. In fact, some clinicians and textbooks recommend treating these neonates up to 7 to 14 days of IV antibiotics. However, there is increasing evidence that a shorter IV antibiotic duration is sufficient and non-inferior. Here at Seattle Children's, our UTI pathway previously recommended 7 days of IV antibiotics, which translated to about a median duration of 6 days in practice. In February 2020, the UTI pathway was revised, reducing the IV antibiotic duration to 3 days for E. coli UTI, which accounts for about 80 to 90% of neonatal UTIs. Thus, the aim of this project was to decrease the median IV antibiotic duration from 6 days to 3 days in neonates with E. coli UTI in the 2-year period following the standard care pathway revision. This here is our project timeline. We collected 4 years of pre-pathway revision data from January 2016 to February 2020. The pathway revision go live was on February 20, 2020. And then we collected 2 years of post-pathway revision data from March 2020 to March 2022. Our data source was from the Seattle Children's Enterprise Warehouse. Patients 0 to 28 days old with the following ICD-10 codes for cystitis, pyelonephritis, and neonatal urinary tract infection were included. Patients who were in the NICU or PICU were excluded because they are excluded from the UTI pathway. In addition, we excluded anyone with a length of stay greater than 30 days and performed a chart review for anyone with a length of stay greater than 14 days to verify eligibility, since either scenario would be quite atypical for patients who would qualify to be on the pathway. Our primary outcome was the duration of IV antibiotic treatment. Our secondary outcomes were hospital length of stay and charges per hospitalization. And to assess for any adverse outcomes, our balancing measures were readmission for UTI, bacteremia, and/or meningitis within 30 days of hospital discharge, and readmission for any reason within 30 days of hospital discharge. So pre-revision, there were 108 encounters that met criteria, and post-revision, there were 49 encounters based on data through December 2021. We excluded 15 duplicate encounters, 7 without a UTI, 4 NICU admissions, 1 patient with meningitis, and 1 encounter was actually a readmission, leaving 93 encounters pre-revision and 36 encounters post-revision. And this again is data through December 2021 that I'll be presenting in the next few slides. This table shows our patient demographics. More than 80% of patients were males pre and post revision, which is consistent with previous literature. There was no statistical difference in the recorded race. There were statistically significant differences in ethnicity and language pre and post revision, though this is likely due to the small sample size. So, for example, if you look at the line, the one line from the bottom at the Spanish language, so pre-revision, there were 2 patients with the preferred language of Spanish, and post-revision, there were 6 patients, but the percentage jumped from 2 to 16%. The next few slides here show the primary and secondary outcomes in a few different ways. So here we have a table of our outcomes. In the upper first table, you can see that there was no difference in the median admission age pre and post revision, 18 days of age. The median IV antibiotic duration decreased from 129 hours pre-revision to 67 hours, which was statistically significant. And there was also a significant decrease in the hospital length of stay from 144 to 77 hours. Median charges decreased from about $52,000 to $36,500, though this was not statistically significant. The bottom table shows just the patients with E. coli UTI. Again, that was the bulk of the patients with very similar results. Here we have a run chart showing IV antibiotic duration. This is including all patients, E. coli and non-E. coli. On the y-axis is the average antibiotic duration in hours, and on the x-axis is the year in quarter. So 20161 is 2016 quarter one. Prior to the pathway revision, there were 3 key publications that demonstrated the non-inferiority of a shorter IV antibiotic duration for neonatal UTI, which may explain the slight downward trend you can already see in the antibiotic duration prior to the revision go live. The go live was again February 2020. In April 2020, I presented to the general medicine attendings about the pathway revision. In October 2020, I presented to our pediatric residents. This was also the month of EPIC go live. I re-presented to the residents in November 2021, though this particular data point here is probably an outlier. Here we have the run chart presented in a slightly different way as box plots with a smooth fit line shown in blue. What I wanted to show here is the striking difference in the wide range of IV antibiotic duration pre-pathway revision with much more narrow ranges post-revision. This was also the case for the hospital length of stay. You can see with a very similar looking graph. For our balancing measure of readmission, there were 8 patients with 1 readmission and 1 patient with 2 readmissions within 30 days of hospital discharge pre-pathway revision. So far, post-pathway revision, there have been no readmissions from any of the neonates. Our next steps are to complete the last quarter of data collection and analyses and to prepare and submit a manuscript. So I'd like to thank Marcine, my project mentor, Chuan for the reason we have all these nice tables and graphs, Daksha for all of the data, QI Scholars Program for their support, and my fellow QI Scholars for sitting through yet another presentation by me. Thank you so much for your time.
Thanks, Paul, for an excellent presentation. Hi, everyone. My name is Meenal Gupta. I'm from the Division of Endocrinology, and I'm very excited to present my quality improvement project titled Improving Access to Care for High-Risk Pediatric Patients with Type 1 Diabetes. And today, I will also be reviewing our findings on disparities in the loss to follow-up rates among patients with Type 1 diabetes. I have no conflict of interest in relation to this presentation. The incidence of type 1 diabetes in pediatrics is increasing, especially following the onset of the COVID-19 pandemic. However, majority of the children with type 1 diabetes are not meeting glycemic targets as defined by a hemoglobin A1C less than 7%. Poor glycemic control puts these patients at risk for both acute and long-term complications. And several studies have shown that the rates of poor glycemic control are higher in racial and ethnic marginalized groups, lower income and single parent households, and access to care remains a major barrier for these families. Missed visit rates as high as 37% have been found in patients with poor glycemic control. We all know that the COVID-19 pandemic caused a dramatic shift to telemedicine, and this was particularly evident in patients receiving diabetes care. Studies have also shown the disproportionate impact of the pandemic on historically marginalized groups, and that this has resulted in worsening existing health disparities. So the global aim of my QI project was to improve access to care for high-risk pediatric patients with type 1 diabetes here at Seattle Children's. Our primary aim was that by the end of December 2023, the percentage of high-risk patients with type 1 diabetes who are lost to follow-up will decrease to 22% from a baseline of 44%. And a secondary aim was that by the same timeline, the mean hemoglobin A1C of the high-risk patient cohort at Seattle Children's will decrease by at least 0.5%. And again, the rationale being that as we are able to bring back these high-risk patients to clinic, that this would result in improvement in their glycemic control. Our study population included pediatric patients with a diagnosis of type 1 diabetes, and high risk was defined as a hemoglobin A1C greater than or equal to 9%. They were defined as being a patient of Children's if they had one diabetes outpatient visit with an MD or an APP during the study period. And loss to follow-up was defined as patients not seen in the preceding 6 months, and this rate was tracked monthly. Our study timeline included a baseline period of 4 years from January 2018 to December 2021. And starting this year in January, we have rolled out interventions, which are ongoing. In December 2021, we created a very specific high-risk loss to follow-up Tableau dashboard, which was aimed at identifying patients who were at risk of being lost to follow-up. And this was used in the interventions. More to come on that in a little bit. So as we were reviewing the baseline data, we decided to use an equity lens and examine whether there was a differential effect of the COVID-19 pandemic on health disparities in the loss to follow-up rates among high-risk youth with type 1 diabetes. And we did this by performing a retrospective cohort study for the baseline period. The study period was further subdivided into a pre-COVID period going up to end of February 2020, and then a COVID period starting March 1st, 2020 up to December 2021. Generalized estimating equations were used to examine associations between 4 demographic variables, including language for care, race and/or ethnicity, insurance, and area deprivation index or ADI, and loss to follow-up rates, and this was adjusted for patient age. In each of these models, a separate interaction term for pre-COVID versus COVID period was introduced to assess for effect modification. 1,366 patients met inclusion criteria and had a mean age of 12.9 years. The proportion of telemedicine visits increased significantly from the pre-COVID period at 1% to the COVID period at 45% of total diabetes visits at Children's. And since the time periods were unequal, we looked at the loss to follow-up rate as the mean number of patients who were lost to follow-up per month, and this number increased from 12.5 in the pre-COVID period to 23.5 in the COVID period. Both of these increases were statistically significant. The participant characteristics are shown in the table on your right. There was fairly equal distribution by sex. The percentage of patients that belong to historically marginalized racial and ethnic groups increased from 31 to 35% from the pre-COVID to the COVID period. And the patients who had a preference of language other than English for the language of care, this number went up from 7 to 9%. The distribution by insurance type and ADI scores remained fairly similar across both time periods. Overall, we found that patients had a 1.95 higher odds of loss to follow-up after the onset of the pandemic. Demonstrating this longitudinally, here is the loss to follow-up rate over the 4-year study period. And as you can see, the rate significantly went up as the COVID pandemic began. Looking at results for each of the demographic variables, for the model assessing the differential effect of pre-COVID versus COVID periods on language disparities in loss to follow-up rates, our interaction term was significant. So this graph is a run chart showing the percent loss to follow-up rates in the pre-COVID versus COVID period longitudinally. The blue line represents the English-speaking patients, and the red dashed line is the patients with language other than English. And the mean loss to follow-up rates for both categories are shown as well. In the pre-COVID period, patients with language other than English were actually less likely to be lost to follow-up compared to the English-speaking patients with an odds ratio of 0.31. Contrastingly, in the COVID period, there were no significant differences found in the loss to follow-up rates among these two groups. With the onset of the pandemic, the loss to follow-up rate increased for all patients, but a more significant increase was seen for patients with language other than English, going up from 4.5% to 24.7%. And for the English-speaking patients, this rate went up from 13.5 to 23.4%. For the race and/or ethnicity model, the onset of the COVID-19 pandemic did not have a differential effect on these disparities in loss to follow-up rates, and therefore results were not stratified by the pre-COVID versus the COVID period. Over the entire study period, though, we found that Native Hawaiian and other Pacific Islander patients had significantly higher odds of loss to follow-up compared to the reference group. And of note that the reference group selected was based on the group size and not to indicate that a particular group's experience should be viewed as the standard. For the insurance and ADI models, again, the onset of the COVID-19 pandemic did not have a differential effect on these disparities in loss to follow-up rates, and so results were not stratified by pre-COVID versus COVID period. Now, ADI, or Area Deprivation Index, is a measure of neighborhood disadvantage score and is composed of 17 measures in the domains of education, employment, housing quality, and poverty at the census block level. At the state level, these scores are ranked from 1 to 10, with 1 being the least disadvantaged block groups and 10 being the most disadvantaged block groups. We found that over the entire study period, patients with public insurance had 1.2 times the odds of loss to follow-up compared to those with private insurance. And for each 1 point increase in an ADI score, patients had 1.04 higher odds of being lost to follow-up. So to conclude, the COVID-19 pandemic exacerbated loss to follow-up rates among high-risk pediatric patients with type 1 diabetes. And with worsening loss to follow-up rates, patients with language other than English were disproportionately impacted by the pandemic. Further research is needed to understand what changes in the delivery of our care, example, a shift to telehealth, may have led to these disparities and whether these disparities will continue to persist after the pandemic. As far as the next steps for my quality improvement project, 2 interventions have been rolled out so far. The first one is highlighted in blue here, which was the same day return to clinic scheduling by the medical assistants during the current clinic visit. As you may be aware, this was an ambulatory-wide rollout at our hospital on January 31st, 2022. And we created specific process maps to implement this at the endocrinology standpoint clinic. We have seen an improvement in the percent of same-day return appointments scheduled from a pre-intervention rate of 14 to 16% to now consistently over 20%. The second intervention, which is highlighted in orange here, was aimed at maximizing provider availability by utilizing unfilled clinic slots. So FSCs, or Family Service Coordinators, started performing outreach calls during their downtime using the scheduling work queue to fill these slots starting in March. And more recently, high-risk patients at risk of being lost to follow-up are being prioritized in this outreach process by utilizing the high-risk type 1 diabetes dashboard. With future interventions, our goal is to continue prioritizing patients in a way that will help reduce disparities. This project would not have been possible without the guidance and support of the entire QI Scholars team, but particularly Aarti Desai, who's my primary mentor, Christy, who's the primary statistician and has spent a ton of time on my project, and it's the analysis. The data analyst, Brian Strub, Daksha, Lori, of course, and support from Lynn and Andrea. Clinical analytics, Liz Park is the one who helped create the dashboard. Daniel DeSalvo from Texas Children's, who's my friend and mentor and has taught me everything diabetes. And my fantastic colleagues from the endocrine division, Faisal, Alyssa, our division leadership, and including our MAs and provider team. So thank you very much for your time and attention.
Thanks, Meenal, and thanks, Laurie, for introduction. My name is Kirti Upadhyay. I'm a faculty in the Division of Neonatology. This was an amazing opportunity and amazing experience to be a part of this wonderful scholarship. My QI project is reducing the rate of pneumothorax in term and preterm infants at Regional Neonatal Network of Seattle Children's Hospital. I have no disclosures. The neonatal pneumothorax is a life-threatening condition that is associated with high mortality and morbidity. It is generally observed in the first 3 days of life, primarily because there are many changes in the lung elasticity, compliance, and resistance that happen around that period. Therefore, the advances in the neonatal medicine have led us to implement lung protective strategies right from the birth, mainly in the delivery room. Two of the most important strategies are the use of CPAP and surfactant replacement therapy, mainly in preterm infants. However, the use of CPAP in the delivery room has been increasing in the preterm infants over the last 20 years. Primarily because there are significant amount of data from the RCTs that exist that suggest that combined outcome of death or BPD in these preterm infants is higher if they had received the delivery room intubations and mechanical ventilation compared to the babies who may have received delivery room CPAP. So in efforts to avoid these intubations and mechanical ventilation, the use of surfactant may be decreased and delayed in the preterm infants. Because of the benefits of avoiding mechanical ventilation intubations in preterm babies, the new NRP guideline in 2011 suggested that using CPAP as a possible corrective measure for spontaneously breathing infants who may have a heart rate more than 100 beats per minute and may have a labored breathing and persistent cyanosis, regardless of gestational age. That's a catchy phrase that NRP had used. However, the data suggested that the benefits only for the preterm infants. Now we know that the CPAP improves FRC and thus improves oxygenation, also reduces the work of breathing, mainly in preterm infants who may have a RDS pathophysiology and the lung characteristics. The effect of positive pressure on the lung volume increases with the lung elasticity and decreases with the chest wall elasticity. Therefore, the amount of pressure required to cause the lung rupture is really inversely related to the gestational age. So there are obvious concerns for association of Ehrlich syndrome such as pneumothorax with the use of CPAP, especially when you use very high PEEP in a preterm babies or even using normal PEEP in a term baby. And we also know that term babies RDS prevalence is very, very low, and therefore the use of CPAP may not be warranted, particularly with the risk of developing pneumothorax. So hopefully with this literature review and background, there are a complex interplay between CPAP, pneumothorax, surfactant replacement therapy, and gestational age may be clear. This is a pictorial depiction of our regional collaborative network. As a division of neonatology, we provide clinical services in several NICUs in the Seattle-Tacoma metro area. This regional collaborative network helps us to standardize practices, reduce the variations, and implement the QI projects throughout. As a part of this QI project, there are total 8 NICUs that participated in this. We wanted to include our referral NICUs, that may be level 2 NICUs, in our project because the delivery room management as a part of process measures that we will discuss again was an integral part, and we wanted to sort of address those so that it was critical for them to be part of this project. So even though I presented literature review first, but what led us to do that literature review is because of this baseline data. Here we from the level 3 NICUs in our center, we are presenting the incidence of pneumothorax in the last 2 years before the project started in 2019 and 2020. As you can see here, our incidence in level 3 is significantly higher, except St. Joe's Medical Center, compared to what's written in the red format, our Vermont Oxford Network national database for the similar NICUs. In some of our NICUs, the incidence is as high as 2 or 3 times. When we further divided or dissected this data, it becomes apparent that the incidence of pneumothorax is more in the extremes of gestational age and extremes of the birth weight. So this is a key driver diagram. It's a busy slide. I will go over some of the main points here. Our global aim was to reduce the occurrence of pneumothorax in our NICU patients by optimizing the respiratory management, with a very specific aim to reduce the rate of pneumothorax as measured by increasing the number of events in between the pneumothorax, and we'll discuss that more in the next slide, by 30% from the baseline within 2 years. We wanted to identify some primary drivers and secondary drivers, mainly aiming at optimizing the respiratory management in neonates during the delivery room, during the transport of this baby from the delivery room to the NICU, as well as their initial and subsequent care in the NICU. So based on the literature review, we identified mainly 3 process measures that may be helpful to reduce our pneumothorax rates. The decreasing use of CPAP in babies who are more than 37 weeks of gestation, near term and term infants, while optimizing the use of CPAP in the preterm infants. And we also wanted to optimize the use of surfactant in these preterm infants, not only the number of babies that receive surfactant, but also optimizing the timing of the surfactant. This is our project timeline. In 2019-2020 data were reviewed from individual NICUs. We compared that with the one benchmarks. By December 2020, the QI Scholar project started, literature review completed, and we started the discussion among within the division to identify the process measures. That was the best part of this QI project. You can imagine how much fun would it be to convince the 40 passionate neonatology to do a practice change, and that to do that all over again in the 8 different NICUs in the entire region. Eventually, we were able to agree and had a consensus. We developed the new guidelines for delivery room management as well as initial respiratory management. These guidelines were laminated and published in the delivery room. We also developed the REDCap survey tools for tracking each and every event of the pneumothorax that happens, what happened, why it happened, and then again doing more brainstorming sessions to see how we can improve on. We were also able to get approval of MOC credit for this QI project, so there was an incentive for people to do this work. We continue to do a monthly QI meetings with all 8 NICUs that participated in here, continued discussions, brainstorming sessions. We did monthly data sharing, data tracking, and continued education. So at the end of 2021, we were halfway, and some of the data that I will present is halfway data. We started the manuscript preparation and completed the MOC project. So this is our outcome measure. Again, to remind, our goal was to reduce the rate of pneumothorax. In here, you can see a control chart called a G chart. The rate of pneumothorax is, even though it's high in our centers, overall rate of pneumothorax is significantly low, and it's very hard to track month by month in a control chart, because few babies high or low during that month can really significantly sway the control chart one way versus other, and may not give a meaningful information while doing the QI projects. Therefore, for the rare events, a G chart for attributable data has been assigned. What G chart means is we are measuring the number of babies that did not have pneumothorax in between the 2 pneumothorax events. And our goal is to increase that number of babies that do not have a pneumothorax in between the pneumothorax event. And that's why desired direction is upwards here. As you can see here in the first part of chart, the center line, it's a mean line, which is our baseline data for the first 2020. And you can see upper and lower control limit, which is 3 standard deviation from the mean. And our goal was to improve 30% from the baseline. At the end of 1 year, we were able to increase this number of babies that did not have a pneumothorax by 45%. The process measures, the 3 process measures that I briefly discussed in the key driver diagram, were use of CPAP in our bigger babies, 37 weeks of gestation. We want to reduce that, and we want to improve the use of surfactant in our preterm babies, and the babies that do receive surfactant, we wanted to make sure that they do receive sooner than later. So this is the first process measures, where use of CPAP in the delivery room for babies who are more than 37 weeks of gestation. Our desired direction is to reduce this. This is the P chart. In here on the y-axis, we have percentage of babies that did receive CPAP, and on the x-axis, we have timeline. As you can see from our baseline data, we have almost 28% babies that were receiving CPAP in the delivery room for more than 37 weeks of gestation. And by the end of 1 year, we were able to reduce that down to 17%. The second process measures is use of surfactant in preterm infants. Our desired direction is upwards here. Our babies that were admitted in the NICU, around 23% of all preterm infants, which are less than 37 weeks of gestation, were receiving surfactant. And by the end of the 1 year, we were able to increase that slightly by 25 or 26%. However, when you further subdivide this into two separate groups, to moderate preterm and late preterm versus very preterm infants, we were giving almost 50%, as you can see on the right side of the graph. 50% of very preterm infants were receiving surfactant, and that number hasn't changed. Almost 50% are still continue to getting it. However, we were able to increase that number significantly in moderate to late preterm infants in the left side of the chart. As you can see, we were able to improve that number by 50% from the baseline. And lastly, the percentage of very low birth weight infants that were receiving surfactant, we wanted to make sure that they do receive surfactant on a timely manner. Within the first 12 hours of life, the utility of surfactant, the data suggests that is better compared to if it's given later. And here in this P chart, again, we have on the y-axis the percentage of babies that are receiving surfactant. We have a fairly decent number to start with. Almost 70% of our babies were receiving surfactant within the first 12 hours of life. And we were able to improve it slightly to 74% at the end of the 1 year. So in summary, the data collection is still ongoing. The rate of pneumothorax is improving, as evident by increasing the number of admits in between the pneumothorax events, a 47% improvement from baseline so far. The use of delivery room CPAP for our bigger babies who are more than 37 weeks of gestation is decreasing. We have observed almost 35% reduction from the baseline so far. And the overall use of surfactant is stable. However, the use is significantly increasing in preterm infants, which are moderate to late preterm infants. We have seen almost 50% improvement from baseline so far. And the infants receiving surfactant within the first 12 hours of life is improving slowly. We started with 73%, and now we are around 75%. I want to thank you and give acknowledgements to all the people listed in these slides and many more that I couldn't put their names here. This is a wonderful program. My mentor, Casey, Laurie for guiding me, Lynn and Barry had done amazing help throughout the projects. Our wonderful neonatology QI leadership team, Elizabeth Jacobson and Meredith Spacey for helping me out in these projects, and wonderful our NICU QI teams that participated. All the 8 centers are listed here. This was a great experience. Thank you.
Hi, my name is Anita Thomas, and I'm a pediatric emergency medicine physician, and I was part of the last cohort of QI scholars. My project is entitled Using Telesimulation to Evaluate the Effectiveness of a Remote Educational Toolkit on Pediatric Status Epilepticus in General Emergency Departments. I have no disclosures. So I'm part of a group called IMPACTS, which stands for Improving Pediatric Acute Care Through Simulation, which is an international group of simulationists dedicated to improving pediatric acute care in general settings, as 90% of acutely ill children in the US present to community emergency departments where the majority of patients are adults. These hospitals may not be optimized to care for the sickest pediatric patients and/or have access to pediatric subspecialists. Approximately 30 to 40% of Seattle Children's Hospital ED patients have a pre-arrival, and that pre-arrival care impacts our subsequent care here at Children's. Through IMPACTS, academic medical centers like SCH collaborate with one another and community hospitals to improve pediatric care. Prior to the pandemic, we would travel in person to community EDs, run simulations with their teams, and help them fill out a Pediatric Readiness Score, or PRS, which is a measure put out by the Emergency Medical Services for Children, or EMSC, to assess an ED's readiness to care for acutely ill pediatric patients. Based on simulation performance and PRS results, each community ED would choose an intervention based on their simulation performance. For instance, many sites chose to work on rapid IV fluid administration in pediatric patients via the push-pull method. This education would be disseminated throughout the next 6 months to their ED. At that 6-month mark, we'd return and obtain a subsequent PRS and run the simulations again with a different group from their team, with the idea that the educational intervention should have been universally disseminated. This iteration of IMPACTS has demonstrated improvement in PRS and simulation-based performance and highlighted the important role of sites who have a designated Pediatric Emergency Care Coordinator, or PEC, in the improvement process. This person is a designated nurse or physician to help improve pediatric readiness and promote quality of pediatric care provided. So then COVID happened and all in-person simulation was shut down. We tried to wait it out, but realized a few months into the pandemic that we could not, given the persistence of the virus and the need for physical distancing. So to mitigate this, we proposed a collaborative that engaged community EDs with identified PECs in remote PRF measurement, distance-based simulation or telesimulation, and targeted weekly educational activities. We performed a needs assessment of existing IMPACTS community sites and found a need for targeted nursing education on pediatric status epilepticus. An educational toolkit for ED nurses targeting pediatric seizure management was established and accessible via vetted free open access medical education, or FOMED, resources over a 3-month period with community EDs that already have designated PECs, with the hope that there would be improvement in PRS, team telesimulation performance, and pediatric seizure knowledge. This data was obtained right at the beginning of me starting QI Scholars and is currently undergoing revisions as a feasibility study. This is our 12-week timeline directly from the paper that is undergoing revisions. PECs in each community ED were trained on the content of the toolkit to be disseminated to their nursing staff who volunteered to be part of this educational initiative. Once completed, this was followed by a remote baseline knowledge evaluation and telesimulation assessment facilitated by 2 members of the study team over Zoom. PECs then disseminated educational material to nursing staff over the following 10-week period. Once the asynchronous educational interventions were completed, PECs completed a follow-up PRS, a repeat telesimulation assessment, and a post-knowledge assessment, as well as a self-reported evaluation of comfort, confidence, and knowledge. Each telesimulation had a critical action checklist reflecting team performance filled out by facilitators, assessing things like time to airway, time to glucose check, time to anti-epileptic medication, etc. Our primary aim was that sites with at least 50% educational intervention completion would have improvement across the board in telesimulation, critical action checklists, in PRS, and would have more engagement in pediatric educational activities. Our secondary aim was that if a site completed at least 50% of the educational interventions, they would have improvement in their pediatric seizure management knowledge scores. Process measures we were interested in included how fast critical actions were being completed during telesimulations, if sites' PRS changed, and how many pediatric educational activities sites were engaged in. We were looking at outcome measures, including completion of educational interventions and how participants' knowledge changed over that time period. Balancing measures, or unintended consequences of our intervention, included the time invested by participants and if there was a change in other pediatric educational activities. We reached out to our existing IMPACTS network of community sites with identified PECs and recruited a total of 17 sites, with 13 sites ultimately enrolling. Of those enrolled sites, we had 110 individual nursing learners start the intervention, with 38 completing it. These figures are taken directly from a feasibility manuscript, currently undergoing revisions, and demonstrate participation, how knowledge changed, how telesimulation performance changed throughout the intervention period. In terms of learner feasibility, you can see in Figure A that learner participation in weekly FOMED waned over the course of the intervention from an initial 60% of participants down to 20% at the culmination. Figure B demonstrates learner knowledge. Of the 110 learner nurse participants, 63% filled out pre-intervention knowledge assessments. Median pre-intervention knowledge scores were 70, while post-intervention knowledge scores were 88, with a p-value of less than 0.05. Figure C demonstrates telesimulation performance. 13 sites completed the initial pre-intervention telesimulation and 8 completed the post-intervention telesimulation. Of these, telesimulation scenario critical action team checklist performance demonstrated an overall improvement in median score from 60 to 100 with a p-value of less than 0.05. This slide demonstrates a main QI aspect of my project in terms of a Plan, Do, Study, Act, or PDSA cycle. After iteration 1, we received feedback and incorporated it into our next iteration. Folks let us know that it was unrealistic to have solely nurses meet a pediatric code in a community ED, even if the rest of the ED is busy. So we made it a requirement to have a physician or APP participant. We also received feedback that 12 weeks was too long, so we shortened the intervention to 5 weeks. We also had the main IMPACT study group take more of a backseat in keeping with the original IMPACTS model, where local academic medical centers, or AMCs, were the main point of contact with community sites and facilitated interventions and telesimulations with main impact support if needed. To ease this transition, we edited the telestimulation platform to make it more user-friendly for local AMC leaders to facilitate, keeping it hosted on YouTube with a Sim on Rails format. Lastly, no site in the first iteration completed the PRS at the conclusion of the intervention, as they hadn't changed anything. So we removed it as a formal measure if sites had previously participated in impacts. We originally had 2 AMCs agree to enroll for iteration number 1. However, one of them deviated from our protocol by just using our initial telesimulation without the asynchronous education, prompting us to create a formal facilitator guide and a letter of intent for the next iteration. While iteration 2 is ongoing, I have the opportunity to present this at an international simulation conference as a work in progress and receive feedback that the telesimulation may be more accessible to trial with the Virtual Recess Room, or VRR, platform, which at that time was gaining popularity among telesimulationists as a low fidelity yet effective medium, utilizing Google Slides and video conferencing with Zoom, as opposed to the original Sim on Rails or YouTube video that you can start and stop. We brought in simulation collaborators from Canada who helped us to create a sample VRR of a myocardial infarction to allow community sites to practice using the platform with a very familiar adult disease process. Additionally, sites from iteration 2 requested that we tie our intervention to CME and a certificate of completion, which we were able to provide for iteration 3. That iteration enrolled 6 sites total and completed in December 2021 with data analysis pending. So for ongoing work, SQUIRE, or the Standards for Quality Improvement Reporting Excellence, exists for standard QI work, and there is currently work to create SQUIRE guidelines specific to simulation QI projects. I had the opportunity to use this project to provide feedback to the SQUIRE SIM consensus group as they refine these reporting guidelines. I'm just about to resubmit revisions for the first iteration as a feasibility study to the Journal of Emergency Nursing, and hopefully it gets accepted. Once that is completed, I will continue to work on the PSA manuscript, which includes data from the second and third iterations. Impacts has since started to reintroduce in-person simulation as per the pre-COVID model. However, our distance telesimulation intervention is still available through the Impacts website should sites be interested. Our model might be an appropriate modality for future study to assess applicability in low resource or difficult to reach settings. I want to acknowledge and thank all of these folks who have helped me along with this research project. Thank you.
Thank you so much, everybody. We have about 8 minutes left, during which we can take your questions in the chat, or if people want to unmute, we can be brave and do it that way. And I will be watching the chat, as will Lori, and we can certainly ask your questions to all our speakers. Thank you. In the meantime, Lori, do you want to remind everyone how to apply for this program and what the deadlines are? I know you already did this in the beginning.
Yeah, that sounds great. So if there are no questions, I would like to highly encourage anyone who's on the meeting today or watching this recording to apply to QI Scholars if you think that you'd like this kind of support for your projects. The application process should begin in mid-June. We'll send out a request for applications by email. It'll also be available on our website. And really, interested scholars would apply with a project in mind. Often the most successful projects are ones that are already kind of underway, or at least have a little bit of footing before jumping into the program, because that allows you to really, access the data, do the analysis, rather than starting from scratch. So if you've got a project within your department or division that you're working on that you think, is related to quality improvement and might be a good fit for getting an analysis and, turning it into academic productivity with a manuscript or national presentation, please consider the program. I would love if there are no questions, if the scholars want to comment at all just about what they've seen as kind of the benefits of the program beyond getting their research done. I do think that, I hope we create a community of interested and engaged QI researchers who can support each other. But I don't know if any of the scholars who are on want to comment on what their experience has been or how they think they might use this training moving forward.
Yeah, I really, I had a little bit background in knowledge about QI, but I think being part of this QI Scholar program was really opened up many other avenues that I felt initially that the QI was very narrow, but the improvement science itself is a pretty wide subject, and there are many iterations of the QI. So I think folks who are looking to develop their professional career in the quality improvement, this sort of opens up many avenues. One of the most important thing that I liked is working with other scholars, and that sort of helps collaborate with the other divisions, as well as many external faculties and networking opportunities. So that was a very good experience.
Yeah, I think I would like to echo what Kirti has said. I think this was a fantastic opportunity. I think particularly for me, I started at Seattle Children's in September and started QI Scholars program in October. And trying to do all of this in the middle of a pandemic, I think kudos to Lori and Lynn and everybody on the QI Scholars team for trying to really make this work and keep the interactive piece of the sessions still alive and kicking, and through Zoom and through small groups, and so it was still, I mean, again, I haven't seen the in-person version of it, but trying to do this in an interactive way over Zoom was still fantastic. It given me a great opportunity to meet and get to know a lot of people who do QI research. And again, like Kirti, I had some experience with QI in the past, but really more focused on actually doing the project. It did not have experience or exposure in QI research methodology and what it takes to really get manuscripts published, and to look at it with, to start a project with that vision in mind, I think is very important. And obviously I've gotten to know wonderful people through the QI network, and I hope to continue to participate with QI work and with this team.
Hi, this is Anita. I just want to echo what everyone else said too. I had barely any sort of understanding of QI prior to participating in this cohort. And it was, Lori'd been telling me for years, like, all your sim stuff is QI. It's totally QI. And I didn't really understand that until I took part in this course. So I super duper recommend it. And all of the contacts have been really amazing. And the mentorship has been phenomenal.
That's so great. We're so lucky to have all of you here, and Dr. Ruttman for running this fantastic program. We're so lucky at UW and Seattle Children's to have you all. I don't see any questions, which means the presentations were just completely complete. So thank you so much for that. And we just have about 2 minutes left. So I think, Lori, Dr. Ruttman, is it okay if we let everybody go back to their Thursdays and just say thank you so much to the QI program, to Dr. Ruttman, and all the scholars for being here today?
Absolutely. I'll put my email is probably self-explanatory, but I'll put it in the chat in case there are questions or anyone would like to ask me more about the program.
Great. And this is a yearly grand rounds, and hopefully will continue to be. So we will see everyone from QI next year, and all of our grand rounds viewers. Thanks for sticking with us during WebEx times, and we'll see you next week. Thanks, everybody. Happy Thursday.